I'm Dr. Rishabh Dubey, and I'm presenting my study on duloxetine as an analgesic in patients without central sensitivity undergoing single-sitting bilateral total knee arthroplasty, a prospective, double-blinded, randomized, placebo-controlled trial. This study is co-authored by Dr. Amin Rajani, Dr. Anmol Mittal, Dr. Vishal Kulkarni, and Dr. Megha Desai. So total knee arthroplasty is a go-to surgery for relieving the osteoarthritis pain as well as improving the function and the quality of life. Over 20 to 40% of patients undergoing TKA remain unsatisfied, which is due to the persistent post-op pain that they have. In this figure, we can see that a significant number of patients complain of moderate to severe pain from post-op day 0 to post-op day 7. Duloxetine, a selective serotonin non-epinephrine dual reuptake inhibitor, is known to be a potent medication in psychological disorders, generalized anxiety disorders, and even in peripheral neuropathy. There have been n number of studies that have portrayed the positive efficacy of duloxetine as an analgesic for fibromyalgia, post-unilateral TKA, and chronic musculoskeletal pain in patients with signs and symptoms of central sensitivity. So what is this central sensitivity? When there is a continuous intense noxious stimuli triggering the peripheral nociceptors, it damages those nociceptors and it gets modulated within the central nervous system, which manifests as allodynia, hyperalgesia, referred pain, and persistent pain, even when the stimuli is long gone. A good example is chronic knee arthritic pain. Bilateral TKA predisposes the patient to post-op muscle weakness and fatigue, and has a negative impact on the rehab of the patient and leads to post-op complications, even in the patients who do not have any signs and symptoms of central sensitivity. Hence, the management of patients who do not have any signs and symptoms of central sensitivity undergoing single-sitting bilateral total knee arthroplasty remains a controversial topic. So the objective of our study was to primarily investigate the analgesic effect of duloxetine in patients who are undergoing single-sitting bilateral total knee arthroplasty without any signs and symptoms of central sensitivity. The primary outcomes were measured using VAS score at rest and VAS score at movement. The secondary outcomes like NSAID consumption, patient satisfaction, and the safety profile were also measured. So this flowchart depicts our study protocol and the patient selection. This study was done in a total 106 patients based on our stringent exclusion and inclusion criteria. The patients who were on any SNRIs or tricyclic antidepressants who had a Hamilton anxiety score or depression score of more than 7 were excluded from our study. The exclusion was done by a psychiatrist who is also one of the main authors of our study. HbA1c more than 7, hepatic or renal dysfunction, cardiac or cerebrovascular comorbidities, these patients were also excluded from our study. So these 106 patients were divided into 2 equal and matched groups. One group was given 20 milligram of duloxetine and the other group was given placebo. The drug was administered from preoperative day 2 till post-operative day 28. A total 30 number of capsules were given. The drug was administered at night 2 hours before going to sleep. And the follow-up was done at 48 hours, at 1 week, at 2 weeks, at 4 weeks, and at 3 months. The patients who missed more than 7 doses were excluded from our study. Surgical protocol included all the surgeries being performed by a single surgeon. No tourniquet was used in our study, but we gave intravenous tranexamic acid before the skin incision in both knees. Spinal anesthesia was used in all our patients. Infiltration in the soft tissue was given through the skin incision, and the physiotherapy and mobilization was started from post-op day 0. In this figure, we can see that the VAS score at the rest at 48 hours, at 1 week, and at 2 weeks in the duloxetine group is better than the placebo group. However, the trends were similar from 4 weeks onwards. Similarly, the VAS score at the movement was significantly better in the duloxetine group at 48 hours, at 1 week, and at 4 weeks, at 2 weeks. But the trends were again similar from 4 weeks onwards. Even the secondary outcomes like the patient satisfaction and the NSAID consumption was significantly better in the duloxetine group in comparison to the placebo group. The adverse effects were comparable in both the groups. However, the nighttime drowsiness was significantly higher in the duloxetine group. But this in turn favored our study as the patients had less nighttime awakenings and had a painless and peaceful sleep. So I would like to conclude my study with saying that the analgesic effect of duloxetine has been well established in the patients who have signs and symptoms of central sensitivity. But in patients who do not have any signs and symptoms of central sensitivity, undergoing single sitting bilateral TKA, 20 milligram of duloxetine, if administered every day, it will reduce the post-op pain, post-op analgesic consumption, and will also improve the patient satisfaction. Hence, it can be an effective analgesic option in the arsenal of arthroplasty surgeons. I would like to show two short videos of one of our patients who underwent single sitting bilateral TKA and was given duloxetine. This is post-op day 2. And this is post-op day 10. So the rehabilitation is much faster when the post-operative pain is less. These are the references for our study. Thank you so much from our team for acknowledging our study at this platform.